Welcome, everyone, and thank you for joining today's webinar to learn about end-to-end eligibility verification automation with Agentic AI. If you're late to the party and watching the recording in your car or on a walk, welcome to you as well. We will actually be focusing today by telling a client story. So we're going to be interviewing our very own Cameron Herwig. He's the head of product at OpenBots. To us, he's a healthcare technology wizard. And specifically, we'll be learning about a treatment center's journey in taking on one of healthcare's simplest yet most expensive administrative problems. That is eligibility verification, unless you want to call it verification of benefits, has a lot of names to it. So let's start with some introductions. So first, let's go with Cam.
Hi there, my name is Cameron Herwig. I'm the head of product here at OpenBots. Our Health Bridge platform, including things like Payer Bridge in this case, where we do verification of benefits, is a bit of my baby and a bit of the project that I primarily work on nowadays.
Excellent, Cam. Very nice to have you. Excited to get deeper into it. So, Rano, without further ado, go ahead.
Absolutely. Good morning, Gabriel, Cameron, and the entire audience we have today. My name is Ronald. I'm the Associate Director of Healthcare Automation Solutions at OpenBots. Well, as an organization, we have been focusing on the front end, middle end, and back end of revenue cycle. But over the past couple of years, we have seen how instrumental streamlining insurance eligibility have been for the healthcare providers. So I think it's a very interesting, intriguing topic, and we're lucky to have Cam today. We're delighted that we have the person who has built the product in the first place. And yeah, like Gabriel, you said, we are looking forward to sharing the story with one of the second largest treatment centers of Florida on how they're streamlining their eligibility process. We'd like to show them what we have been able to do for them. So yeah, excited for this topic and really, really looking forward to it.
Absolutely. And I think what's happening here is that eligibility is widely viewed as a solved problem. There are so many different kinds of tools, but the reality is that denials are still the highest they've ever been of all time in healthcare. And the number one reason for denials is still specifically eligibility and a lot of issues that stem from doing it incorrectly. And when it comes to clearinghouses and EHRs, there are solutions, but we have an approach here that tends to attack denials at the root cause and attack the issues that are making orgs lose money in the most practical way. So let's get into it. So specifically, Cam, how about you discuss the top 3-4 pain points that existed for eligibility for this specific treatment center?
So for this treatment center, they really probably had the three major pain points of taking in patients that are currently in a grace period. That creates some uncertainty about whether or not they're actually going to get paid by the insurance in this case. That's a huge financial risk for them. They could lose tens of thousands of dollars if they are not able to get paid and they do admit this patient. And as it stood with the platforms they were currently utilizing and the portals they were currently utilizing for performing VOBs, they just weren't getting that grace period detection. They would need to get it from the phone call that they do out to the payer. And even then, sometimes those reps were hesitant to give that information or a bit cagey about giving it, because at the end of the day, it is in the payer's best interest to allow that patient to get admitted. So that's a big pain point, is detecting those grace periods in a standardized way so that they can know ahead of time, hey, we might not want to admit this patient. We need to do further checks before we do so, make sure they've actually paid for their policy and are not in that grace period going forward. The next big one is very related, performing those phone calls to those payers. For some payers, this might not be a big deal. Quick phone call, batch, get a few patients done, maybe a quick hold time. But there's payers out there where they were experiencing 4-hour plus hold times for one phone call where they can do a few patients at a time maximum. And that's particularly painful. That just eats up your whole day, ties up an agent. So if we can get the information that we're getting back to align relatively one-to-one to what they're getting from that payer on that phone call as part of that VOB verification, they don't need to perform that phone call. They can move on from that, get to other work, and at the end of the day, just have more throughput. The next one is going to be dealing with too many payer portals, or dealing with too many portals where they go to actually perform these VOBs. So whether that be that they're doing some of them through Availity, some of them through a platform like Navinet, going out to the actual payer portal for other ones, you end up managing lots of shared logons or individual logons, having to open up lots of different portals throughout your day, go through the sign-in process, deal with the multi-factor authentication. It's a time waster. And you do all of that work just so that you can go in and copy and paste a bunch of values into your end system from that payer portal, when things could be done much more elegantly from the back end. And at the very least, we can get rid of all of that data entry. So those are some of the major ones. There is some minor pain points, detecting in versus out of network coverage for particular facilities against particular payers based on contracting, dealing with slightly inconsistent information that you might get from different payer portals, just it being structured slightly differently. But the big three are going to be handling those grace periods and detecting those, trying to eliminate those long phone calls, specifically the hold wait times, and standardizing so that you're not going out to a variety of different portals to get that same information.
That's excellent information, Cam. Really, really appreciate that. And yeah, I mean, we would like to go into the demo and stuff where you can give us more clarity on what the main problem was there for this group and how we have been able to solve it. But before you go into the demo, one thing that we did observe, Cameron, is that this treatment center was already using another vendor for the eligibility verification process. So there might be some gap which they realized in the first place to kind of change that vendor and replace it with OpenBots. So as you slowly progress towards the demo, why don't you kind of tell us about the differentiator of what we are able to provide versus what is missing in the current eligibility verification vendors that are available?
So the vendor that they were utilizing had two particular gaps that they were concerned about. It did not provide them a very easy way to detect whether or not a patient was in a grace period. This information is often available in the 271 response that comes back from the payer. It's just hidden away in coverage notes and payer messages. And that was not presented to them in a way that they could actually action on it from their current vendor. We were able to do so through our rules engine that I'll talk about in just a moment. The other big one would be that the vendor that they were utilizing at the time didn't do a particularly great job at handling other types of overrides that they might need from their rules engine. So let's say, for example, that they have pre-negotiated rates with certain employers. That's actually very common with them. The vendor that they were utilizing didn't provide them any mechanism to set specific coverage values based on things like group name or prefixes. For federal plans, you might have a group number prefix that you can go off of to actually set the coverage ahead of time. And what that led to was them getting incorrect results from the verification, having to perform the phone call anyway to get the correct results, and really not making any progress by doing the VOB automatically. So the way that we tackle that is we have a bit of a layered system for how we structure things to get it to the clearinghouses. We then get the data back from the clearinghouses, standardize that for ourselves, run it through our rules engine, both for aligning how different payers report things to make sure everything's coming through the same way, as well as perform a series of overrides that can be configured. So to talk those through, first and foremost, you register your facility in our system. In this case, I have two facilities pre-registered here. We're able to handle facilities with a variety of aliases so that if you're calling us from multiple end systems, you don't have to use special lookup tables or anything like that to make sure you're telling us the same thing every time. You can go through and just say, hey, this is the facility name that I want you to process. You're then able to set the default facility for a particular state. This is important for matching up facilities based on patient addresses in the case of things like telehealth. So I can say, hey, I have a patient that is a telehealth patient. They reside in Florida. We're going to treat them under our Florida facility for the purpose of performing that benefit verification. You then have the ability to map in different payers. So we support 3 different major clearinghouses at the moment. We support Availity, Waystar, and Navinet. We are pushing out support next for Steady and then a series of other clearinghouses as we work through the different available options on the market. The idea of supporting these different clearinghouses is it allows us to get information from as many of them as possible if we have access to them through our own keys or through the customer's keys, or in the case where we want to get information from multiple clearinghouses and consolidate that into a single record, we can do so. Alternatively, we can align the best payer to their clearinghouse. So in the case of, let's say, Oscar, they may give better data through Availity than Waystar. You wouldn't think that there'd be a difference there, but there can be quite a substantial difference in how they report things like service level benefits through these different platforms. So in this case, I've got two OpenBots facility payers registered here, one for handling all commercial plans and one for handling Medicaid plans. If I drop down into my demo page where we get a nice pretty output for the purpose of talking this through, I can go ahead and take a patient such as Jordan Mercer. Drop in their date of birth, drop in their member ID. The payer I'm going to select for them in this case is our commercial payer. We do have the ability to specify against a specific platform that we want to run this against. In this case, I'm going to do my Waystar platform call, as that's the payer mapping that I have configured for this payer. And then for the projected facility, we're going to go ahead and select our Florida facility. Submit that VOB request. It goes to our backend engine, which should pick it up in a few seconds as it did, and goes ahead and processes it. So in this case, what we end up back with is a patient where their coverage started a couple months ago, is good through 2027, comes through as a commercial category, and comes through with specific service level benefits. So in this case, we can get the benefits for detox, residential facilities, partial hospitalization, intensive outpatient, right, telehealth, and we can get those specific service level benefits to the degree of getting $250 copay for these, no copay for these, what's the coinsurance for each of these different benefits. We also get the generalized benefits for that payer. So regardless of the specific service level being provided, the baseline benefits are a 20/80 split with a $35 copay. And then we get back those deductibles and out of pockets as well for both in and out of network. Now, if we were dealing with a patient that is out of network, right? Let's say that the facility that they are going to is out of network with that particular payer. The way that that's reported by our system is pretty straightforward. It will go ahead and it will only provide out of network benefits. And this is handled all under the hood. So if I were to go ahead and say Georgia in this case, it'll come through that we have no coverage for in-network for our different service level benefits. We don't have any in-network coinsurance values or copay values or deductibles or out-of-pockets in this case. The only thing that will apply to us are these out-of-network benefits. So that's how that's presented through that. The next major piece of this, when you're not dealing with just a standard coverage call or a standard verification of benefits, is overrides. And this is really a big differentiator for us, is that we provide the ability to configure hard overrides across everything from, as I mentioned, group name, member ID prefixes, the different validation messages that we can trigger, such as grace periods, tiered plans being detected, different insurance categories, such as detecting a Medicaid plan. And based on that, we can action and then adjust the coverage result that we give back. So let's say in the case of a grace period, our engine detects that a grace period was enacted on this patient somewhere in their payer messages or their coverage responses. We throw a validation message based on that for a specific grace period. And when that is detected, we will flag that we're not going to admit this patient. We're going to give a very explicit reason that the patient is in a payer grace period, and we need to verify status before any further admission steps take place. And at that point, the record is updated fully. So if I go ahead and grab Taylor Bennett, and I go ahead and set them up under the commercial payer to the Florida facility. What's going to kick back is that a grace period was detected, and then the specific messaging. This messaging closely aligns to one of the bigger payers that we work with, which is that this member is in the first month of their grace period. Claims will be processed according to the terms of the contract. Additional claims in the second or third month may be pending until the outstanding premium is paid in full. And that's the risk there. Will the outstanding premium be paid in full? Will you get paid as the provider? So we still have their full coverage results available to us. This still gets placed in the end system, but we do trigger that we are not going to admit them, at least initially, and we do set the notes accordingly to make it very explicit as to why we are setting that do not admit flag. Okay. Let me go see what we have next on the docket. So talking about some of the further overrides that we can go ahead and do. We can detect something like a Medicaid plan. And in the case of knowing that a Medicaid plan gives you full coverage for your services, we can set all of the various values that you get on a VOB output and explicitly set those and say, hey, this member is going to be covered at 100% because this is a Medicaid policy. We have the ability to do logic like not set coverage values in some cases. So let's say we're dealing with a tiered plan. One of the nuances of a tiered plan is that you don't necessarily know at the time of performing the VOB backend call what tier the provider is in with that particular payer or at that particular facility. So rather than setting incorrect coverage values across the whole record, we don't know if you're tier 1, 2, or 3. We can actually then clear those off and leave you a very explicit message saying, hey, we detected that this is a tiered plan. You're going to need to do further steps manually from here. Just to go ahead and show you what that looks like. We'll grab Morgan Hale, born in 1990. And Morgan, in this case, is going to have a plan with a tier 1, 2, and 3 in it. At the time that we perform this VOB call, we don't necessarily know what tier we're in. This changes our deductible quite substantially here as to whether or not we are a participating provider or a preferred provider. So we need to contact the payer to determine which tier applies in particular. And from there, the actual coverage values would get populated by the agent having made the phone call in this case. Finally, as far as the major overrides that we can go ahead and do, we have pre-negotiated rates. So this is our ability to detect things like the plan name being OpenBots or the employer name being OpenBots Strategic. Based on that, we know that we're in their preferred program, and we can set some preset coverage values. We know we'll have in-network coverage. It'll be a 90-10 split with a $15 copay and a $500 individual deductible for that entire visit. And we can set that explicitly, regardless of what the coverage values that come back from the payer look like. So if I go ahead and grab Riley Monroe, born in 1993. Set him up to our commercial pair, to our Florida facility. There you go. When we make that call to the clearinghouse, it will come back that he is a employee of OpenBots Strategic Accounts. Accordingly, we set the plan name as we specified in our override, set the service level benefits to what we know they'll be, and set the co-insurance values accordingly to the prefixed values that we know we're going to be dealing with based on what we've negotiated with that employer. So that's the major things that we can do in the rule engine at the moment. Obviously, it's very flexible. It's a configurable engine. These are just the primary examples that we've worked with thus far. You can do everything from, as I said, detecting federal plans and group names and setting pre-negotiated coverages based on those, detecting that when you have a tier plan or a grace period or any other type of validation message that we throw, toggle to particular flags, toggle particular coverage values, and add explicit notes to your end agent saying, hey, you need to perform these next steps. A big one that we've discussed in the past is detecting that based on a particular employer name, you may not have pre-negotiated coverage values, but you also may have to call, or you also may have to send a fax to get the proper negotiated coverage values from that employer in this case. We can kind of front run that for the end agent, give them those explicit instructions as to what their next steps are, and prevent a little bit of back and forth for them where they try and call them, maybe they don't get the right details, then they need to send an email. Whereas we can tell them up front, here's the next steps that you need to take. They don't need to memorize this for every payer in the pool. So I would say that's about where we're at from a baseline of the demonstration set. Gabe, Rano, any questions that you have?
No, I think first of all, we can clearly visualize why there are so many problems if you really take a deep dive on the insurance verification process. It sounds simple from the overview from the surface level that you're just checking coverage and service level details. But some of the things I'm seeing, like identify if the patients have a Medicaid policy or not, because Medicaid is going to be fully covered.
Mhm.
Identify whether it's in network or out of network with the insurance company. So I think I understand the nitty gritty of it and why it is so fundamental for this treatment center to have a product like this. One of the things that I've been hearing from you quite a bit, Cameron, is grace period. So if you can help us understand what happens to the patients who are on grace period and how significant is this grace period information for this treatment center?
From the perspective of the treatment center, it's critical. So this is a patient that either may not have paid the premium of their insurance plan, which means they may not be covered, or if they have paid it, the backend system has not updated to reflect that. That creates a lot of risk. If you admit that patient and they have not paid their premiums, they may have their coverage dropped. And then you have a patient that is admitted to your facility that you've been providing services to that is no longer insured. And they may not have the cash to cover this out of pocket. They may have no intention of doing so, right? They may have been admitted, and from their perspective, they admitted with their insurance with the intent that their payer covers it at a 90-10 split, and they're going to owe X number of hundreds of dollars for the entire service. And suddenly that bill is 10 times that. So that is your risk. And as the treatment center, you then assume that financial risk of having to then negotiate with the patient, determine how you're going to get paid for these services, when alternatively, you could have detected that a grace period is present, identified that risk is there, and then perform next steps and checks based on that before you admit that patient.
Beautiful, beautiful. That's key for this client. And I think one of the things you mentioned that was super important too is phone calls. Phone calls is like the bane of existence of anyone in healthcare administration, to the point where there's so many dollars on how do we even take over phone calls with technology. But one piece, which is usually better, what you mentioned, is preventing the phone call at all. Is there a way that you don't even need to make the phone call? And you were breaking down how, for let's say there was 10 phone calls that need to be done, that has decreased significantly based on being able to get the results and check multiple portals for that data. So tell us a little more about that, Cam. Like, how do you actually use technology to decrease the need to call payers?
So the big thing here is that it's very payer by payer. There is payers that have very large call centers and maybe not a lot of volume on that particular day, and you'll get through pretty quick and it won't be a problem. But it is to the level that when you talk to these VOB agents, there is notorious payers for their hold times in the magnitude of hours on average, and it doesn't ever get shorter; it only gets longer. And they go into their day knowing that if they pick up a few patients in their queue for a particular payer, that they're going to spend the next 4 hours on hold, right? Trying to get access to an agent where they can then verify the benefits for those patients. Now, not every payer is going to have their systems be perfectly up to date. There is going to be times when we do calls out to these different clearinghouses, and there's a couple benefits that still need to be confirmed with the end payer when you perform the phone call. But there's a substantial portion of the time where what we're providing is one-to-one to what we're able to get off that phone call. And it's more up to date than what is necessarily on that payer's individual portal. Or maybe that payer requires you to send an email or a fax if you don't do a phone call. Or maybe you can only get it through Availity, but when we call Waystar and Avinet, we get slightly more up-to-date coverage details. There can be any number of reasons that a payer or that a provider at the moment when they do these VOB pools through these portals that they're using aren't getting the most up-to-date information, are having to do that phone call to get the correct information. And then when we do it through our system, where we're hitting a variety of clearinghouses and a variety of portals and consolidating that information at the end, we're able to get slightly more up-to-date values than they are currently with their existing process. So in those scenarios, we're able to just eliminate the phone call entirely, right? We can work with the VOB agents, do verifications against some of their highest volume payers, confirm that the values that we're getting for them are one-to-one what they're getting post phone call, and just cut the phone call out of the process. And we've already been able to do so for some of the highest hold time level payers that this treatment center deals with.
That's phenomenal. But that, so basically what you're saying is that Number one, gone are the days of a VOB agent manually going to the payer portal, entering a bunch of data, waiting and having to go through multiple screens from your EHR to documentation, all that. So that's one piece that's basically gone with automation, and basically almost like having this as the aggregator of all aggregators. So every client we have has so many different payer portals, and it helps because it's not an individual payer. You have the clearinghouses and the aggregators that help with that, but none of them have all of the payers. But basically, this does have all the payers because or as many payers as you can, because it's integrating with all of the main clearinghouses. Now, question: how do you tell us a little bit of your experience? Like, how do you know if the results are inconsistent or inaccurate? Like, what's the source of truth? Like, how are you using all of these tools to make sure you have the most accurate data for every patient?
So we have a substantial amount of tooling built into the engine in the back end. One of the most critical for us is the ability to then, using all of the connections that we have available to us across our clearinghouses, run a particular patient record through each of these clearinghouses, directly compare the results that we're getting back one by one, side to side, and determine who's giving us the most up-to-date information, who's giving us the most explicit information as far as service level benefits. Different payers choose to report service level benefits under different codes. And our engine does a very good job in the back end of, regardless of what code it's being reported under, categorizing it properly and making sure that that's actually reported in our end object. But we need to be sure that when we pull from these different clearinghouses, that they're all giving us all of the service level benefits. And payer by payer, that is not always true. There is a fair number of payers that give a bit more information to different clearinghouses from our experience. So using our tooling, we identify that, we determine who's giving us the most information. We then go back to the business, we review with the business and say, hey, for this high volume payer that you're dealing with, here's our coverage results. As you can see, if you have any issues in your processing with your coverage results that you're getting back, we have the ability to report feedback directly to us. So in the case of this particular customer, we integrated with their CRM tool. We gave them the same capability from their CRM tool to provide us feedback, but it exists natively in the platform, that when a VOB agent comes through and is reviewing a record that we pulled, let's say that when they went into the nuts and bolts and they did the phone call, they came out with $150 for the copay for detox instead. They can provide us that feedback. That triggers to us to do an investigation. We check against all of the available clearinghouses that we have for that particular payer. Who is able to give us that information? Where can we get that $150 copay? And from there, we can make tweaks in our backend to ensure that we're getting those correct coverage values on the first try.
Fantastic information, Cam. Cam, I have another question in terms of the frequency of eligibility runs, and I'll tell you this from my experience. We do work with obviously many other healthcare organizations where we have seen that they have a specific trend that they follow to run the eligibility check for all the patients. They would typically tell us that OpenBots, as an organization, you need to focus on running the eligibility check for all the patients on the middle of the month and on the last day of the month. And the reason behind that is we typically see that the policies would lapse in these time periods. But for the other patients who would have an appointment in the next 48 hours, you need to run the eligibility check perhaps 24 hours before or 48 hours before. So that's kind of the set of criteria or guardrails that we have to follow. But for this particular example, Cam, what are we looking at when it comes to the frequency of eligibility check for new as well as old patients?
So for this particular provider, what we're really concerned with is verification of benefits on admission, and then a rolling census, where for the entire patient pool, we will do a weekly census where we'll do a big batch processing overnight to confirm that everybody still has benefits, double check everybody's deductibles and out of pockets compared to their maximums, and determine to what degree we can get paid for these services, and actually do financial calculations based on those figures as well. So for this, it is on admission and then on a weekly census. That census capability is currently external to the platform. There will be updates to the PayorBridge platform relatively soon to add in that type of batch processing natively, where we can keep a patient census pool in mind ourselves, and then in the background run these on a fixed period as well.
And that's fascinating, because when it comes to tooling, right, like there's intake and registration tools, right? There are EHRs that have native soft eligibility checks, right? There are clearinghouses that also are aggregators. There are aggregators that are clearinghouses. There's so many different technologies that healthcare providers have access to help with this. Our understanding from our client feedback is that a lot of it is so standardized that it's not solving the issues, in this case, of either admitting patients that won't pay you, or in the other case of getting denied because of things like coordination of benefit errors where you're billing the wrong payer, or benefit maximum issues where a client has actually reached their maximum. So tell us a little more, like if a client is using OpenBots for eligibility, what tools do they actually need? Like, what's the perfect future state for tooling to solve these problems?
In the long term, the idea is that we can build everything into our tooling. So we've got a very flexible platform in how we build things. We've got a lot of experience building solutions across a couple different industries in the past. What that has led us to do is try and build very configurable software. So the idea is I don't try and solve just the problem of getting you the benefits. I try to solve the problem of getting you the benefits how you need them, not just how the payer gives them to me, how you need them. So this can be applied in a variety of different ways across the different segments of these problems. Um, the long-term end state here is you hope that the OpenBots tooling operates as kind of your one-shot provider when it comes to dealing with the payers, whether that be through us aggregating across the various clearinghouses or going out directly to the payer through their back end as well. And then we're able to use our automation tooling that we've had for a number of years that comes with our platform to get our data back into your end system ourselves as well, whether that be through traditional software automation, whether that be through Fire connections that we provide through our Health Bridge, to interact with your EHR directly and get those benefits in place. The idea is that you submit a request to us, or we determine that you have a request for us using our automation tooling. We process everything ourselves and we get it back into your end system without you needing to do anything.
Wow. So basically, that makes sense. And you talked a lot about the rules that can be incorporated here. So tell us a little bit more about this specific inpatient treatment center and the kind of rules that mattered for them around Medicaid or Medicare, things that they were dealing with.
Yeah, so as we talked about with the overrides, right? In the case of detecting grace periods, knowing that we're not going to admit that patient. In the case of Medicaid, knowing that we have full coverage for that patient, or a tiered plan, knowing that we need to do a follow-up call. I mean, some of the other rules that we have implemented that I don't have shown here in my demo portal are things like the ability to trigger to an agent, hey, you don't need to remember that you need to go send an email to this particular payer. We're going to tell you that you need to do that. You don't need to just have that in your head and teach that to the next person you hire, or have it in some obscure Word document somewhere. We can document that directly in the case in your CRM or in your EHR through the notes that we provide as part of our processing. Being able to standardize based upon group names, group numbers, prefixes to the member ID for particular payers, and knowing what those benefits are out of the box. There's a whole swath of those that we can apply. And those can change yearly with the contract. So these aren't built into the backend engine in a fixed way where we need to go do a new release with code changes. It's as simple as them coming in and making the quick adjustments to the coverage values that we override and setting those to their new values once they renegotiate that contract. Um, those are really the big ones, right? The idea being that we can get any type of legacy documentation kind of built into the engine so that it's put in on the records that are being created in the end system. And we can handle the little nuances of processing that are specific to you as a provider, or for even for a particular facility and against a particular payer, and minimize the amount of work that the VOB agent is having to do to go make corrections to the values that we're getting back from the payer.
What I'm hearing is that the main value here is realistically out of everything that's happening, like automating all the mechanical pieces and automating all of the checks on endless payer portals. It's really about the interpretation of the 271 response, the intelligent automatic interpretation that previously you needed subject matter experts for, but we've gotten a lot of that knowledge and it's happening automatically for each one of our clients. So tell us a little bit more about that, whether it's for in-network and out-of-network, whether it's for co-insurance, whether it's making sure the deductible is met or not met, and how is it interpreting all of that? Like, how did you actually pull all of that data together into one engine to do that?
Yeah, so what's happening on the back end is as we've integrated each of these various clearinghouses, we've worked to standardize what they're giving us back, build on top of it to then determine based on which payer that we're dealing with, what adjustments do we need to make to our processing. And the big one is putting AI models on top of it to actually detect the proper service level benefits, structure things appropriately so that we can provide the little nuances. You know, different payers, especially with service level benefits, report in very different ways. And there's a lot of nuance to service level benefits. A very important one could be that we have a patient that it's a $100 copay for 5 days for detox, and then it's covered at 100% after that. And three different payers might report that in entirely different ways. So we've put AI modeling on top of that to take in the service level benefits that we're getting back from the payers that we're interpreting into a standardized format, and then analyze that and say, all right, I don't care if this is code A7, A8, A9. I know that the benefits as they're being given to me by this payer correspond to detox. I can see that my visit limitation is 5. I can see that the copay is listed at 100. And then I can see that the co-insurance value is listed at 100%. So based on that, I can interpret the service level benefit of this particular level of care to be $100 copay for 5 days, then fully covered after that point. And then reporting that down to the end provider system accordingly, as their agent would put that into their end system as well. So a big thing for us is making sure that we can align how our outputs look in that end system to how these VOB agents have been doing this for years, to not provide any breaks in the process or substantial retraining, just so that they can learn to interpret our results. We match it up one-to-one to what they're seeing on their end once they fill in these records.
And to take it a step further, so not only are 3 different payers evaluating the exact same situation differently, you've mentioned too that you might have one payer that exists on many clearinghouses, and when you go to each clearinghouse, you're also getting different information. Talk about that a little more too. That's fascinating.
So it's not so different in that you're not going to get the same deductible, although you might get the different accumulations depending on who's more up to date on their batch jobs at the time. But what will be substantially different is exactly those accumulation figures or how they report service level benefits. So in the end payer system, they obviously have it written down somewhere exactly what the coverage value is going to look like for partial hospitalization programs. But the way that 271 response gets interpreted by the clearinghouse and provided to you as the end system integrating with them may be slightly different, and details may get left out, or things may not be always reported. So we've seen it in our experience that something like a partial hospitalization program, when coming under one clearinghouse, might be bundled under a particular service code, or in other cases, it might get dropped off entirely. By giving that coverage across the clearinghouses, we can very much ensure that the payers that we're trying to VOB against, we're getting the best possible information. Unfortunately, most of these payers do not provide a way to directly integrate with their backend systems. You do have to go through some type of clearinghouse. So we select from the best available there. In the case where we can go directly to a payer's backend, we do try to do that as well.
Quite interesting, Cam. Obviously insurance eligibility is a big problem. We are trying to obviously go into the details and see what are the major roadblocks that would eventually be solved with the help of AI or any other technology. So I think it's quite comprehensive. I think some of the things that you have showed us today, it's really reflecting why insurance eligibility is one of the main reasons for the denials to happen in the first place. I mean, if you look at the stats, 24% of all denials are somewhat related to insurance eligibility. which could be prevented if you are having a proactive interest in it. The other problem that we are also solving, Cameron and Gabriel, is prior auth. As we all know, that insurance eligibility and prior auth are very tightly linked, and they're almost part of the same chain. So for the audience we have today, Cameron, can you give us a teaser of the prior auth solution that we are building, and particularly the intelligence piece of it? Like, how are we using prior auth's intelligence to prevent the denials that eventually happens from prior auth?
So I won't get too deep into it, partially because I don't have a whole demo set up for it at the moment in my clean environment. But
Right.
and I'm not going to show my provider information in this case. What I will say is, when it comes to prior auth cases, what our engine is trying to do is it's trying to evaluate a prior auth case based on the current clinical documentation that we can have available and say, what is our chance of approval or denial from this particular payer based on what we understand about this payer's guidelines and about what they look for in a particular case for this particular clinical pathway that we've identified that this patient is on. So there's a few layers here. You will have a prior auth case with a lot of documentation in it, right? In the case of the provider we're working with, this can be about 10 documents on average, with about 10 pages each on average. So we're dealing with about 100 pages of clinical documentation per patient. We're running that through our IDP engine, our OpenBots document AI tool that is very good at its job, and then getting out all of that clinical documentation, whether that be in a very structured way or in a very summarized way, depending on the type of document that we're dealing with. We're putting that into our prior auth engine, and we're saying, hey, what clinical pathways is this patient on? So we have the ability to go in and define a clinical pathway where we can say that, hey, based on this criteria, whether it be a clinical, treatment, a concurrent, or an override criteria, and a description of what that criteria is, does this patient meet this clinical pathway? Are they on a ventilator? Are they a ventilation patient? Do they need wound care, right? Do they have substantial wounds that require long-term treatment? So we categorize these patients into these clinical pathways, which are the same clinical pathways that are used by the payers at the end of the day to give authorization for admission based on that service. We then have payer-specific guidelines. So for a particular payer, what is the guideline they have? What are the care settings? What are the global requirements? What are the admission rules, the continued stay, and the discharge rules for this particular payer? And then we take all of that clinical documentation we have and all of that data we've pulled off of it, and we feed it into our model, and we say, based on this patient, what clinical pathways are they on? Based on the clinical pathways that they are on, which of the possible payer guidelines apply, and do they match those payer guidelines? So we can get very detailed. We can tell you on an end case that this particular patient just barely didn't meet this particular criteria for their clinical pathway. And they also just barely didn't meet this particular guideline for the payer based on the clinical pathway that we evaluated them against. And we can give you a recommendation and say, hey, you have 3 out of the 4 weaning attempts we're looking for in this case. Go back and get an additional weaning attempt before you perform a submission. You're much more likely to get approved.
Absolutely. I mean, when it comes to eligibility and prior authorization and utilization review, it goes hand in hand, but that's fascinating. That's the same thing. What you're talking about is the intelligence around how you actually can predict whether or not you will get denied per procedure, per payer at a very granular level. And then the engine will actually suggest specifically what to do, whether it's to add a specific piece of documentation that was added before to get approved, or whether it's using the correct code, or whether it's having a specific rule that wasn't met. Like you said, like if the patient has to stay for a certain amount of time, like in your case, 21 days could be, hey, the patient has to stay for 21 days in long-term acute care hospitals to actually make sure that they can actually not get denied, basically, or continue to getting the service they need. That makes sense. So let me actually recap this. This is so far, Ken, thank you for your time. It's been a very good breakdown of this. So in this case, for eligibility verification automation, the main point here is very basically denials versus admissions. a lot of healthcare providers have the issue with denials. They had the issue where they were losing money because they were admitting patients that were not going to pay, because the patients were usually in some kind of grace period that's usually about 3 months, that basically they might have showed as green active on the payer portal, but in reality, active does not always mean billable. They were never actually going to pay because they had not paid their premium. So being able to have technology that can assess that is key, not only for the provider, but for the patient. The worst thing that can happen is the patient needs care, is getting care, and then that care has to actually stop in a way that, while they're actually getting treatment. That's not the best approach. And number two is also all of the manual labor needed to go through all the payer portals. That goes away after this. So that's basically a culmination of kind of what we discussed today. Cam, any comments on that, or what's your, I guess, your main feedback to a healthcare provider looking at this kind of technology?
No, I think you did a super good job covering it. I would say that for anyone that's looking for similar solutions or dealing with an existing vendor, evaluate yourself how much work your agents are having to do after the point of the VOB call that you're doing out to this existing vendor, to standardize things to how you want it, or make corrections that you're having to make after a phone call. Uh, there can be a better way to do these things. And think about what types of criteria and what types of detections that you need that could simplify your life, right? Could just make your agents' lives easier. A big one in this case was grace periods and tiered plans, right? Being able to call those all out off the rip made life a lot easier for the VOB agents. There is ways that you can do these things, you can detect these things, and you can set it up so that when the case gets to your VOB agents, a huge part of the work's already done.
No problem, no problem. And we do actually have one question that I had missed from Tushar.
Sure.
The question says, when you say how you need them, it means there will be a lot of configuration. How does it handle all the configurations needed? Go ahead.
So processing works in stages in our engine. So there is the stage where we call all the clearinghouses that we have configured for that particular pair. That gets us the raw 271 responses. We then standardize these raw 271 responses, and based on the pair that we identify we're working with, make the slight corrections we know we need to make. In that case, once everything's corrected, everything's in our standardized object, it passes to the model to begin processing. Now, that model is not working off of a set of generalized instructions. It's actually working off of provider-specific instructions that are tied to the organization that you're in. There is a baseline that gets configured, but you are able to correct that. And what that lets us do is that model is able to change any field on that coverage object that we create, including the general notes, including the service level benefits, deductibles, copays. It's able to make those tweaks it needs to make. So the big thing for adjusting how things get reported to you to meet like kind of the criteria and the format that you want is tuning those instructions, right? The engine level instructions, and we provide that capability just natively in the portal. From the perspective of adjusting for specific rules that you may have in as an organization, when we see a Medicaid plan, we do this. When we see a tiered plan, we do this. When we have a patient that has a federal Blue Cross Blue Shield plan with a 104 group code, we set these coverage values. That can all be handled through that override section. But when it comes to things like how we format these notes, and that we're providing the VOB facility that we're doing at the top, and providing this very nice structure for these very particular service benefits in these notes, that all comes from those engine level instructions. So if I ran this in a new organization, the general notes would not show up this way. They would just show a very brief description of what the coverage looks like. This is tuned specifically for a treatment center and could be retuned for any other type of provider.
Well said. Well said. And to that point, in most situations for outpatient and ambulatory environments, there's 4 main things needed when you're looking to automate eligibility. Number 1 is finding a way for multi-portal submission. The value here is basically one intelligent engine across all payer sources that completely takes off the manual entry and all of the dealing with all the fragmented portals. Number 2, the biggest issue when it comes to eligibility is eligibility denials related to coordination of benefits. Remember that half of all eligibility related denials are specifically because of coordination of benefit issues when the wrong payer is billed. That could be because you have a spouse that has a specific payer that was built as a primary. That could be because the date of service is incorrect. That could be because the payers were sequenced incorrectly. That could be for a variety of issues, but using automation can make sure that your payers are in the correct order and always billed appropriately based on the rules that's needed. Number three is being able to actually integrate directly with your EHR. That's a given. You need a way to be able to automatically make sure the information within your EHR is consistent with the data in documents and the data on payer portals. And number four, the last piece is making sure that you're not just doing soft verification of benefit checks. A lot of times when it comes to the native EHR functionality, it'll give you surface level information. It won't give you all the service level details you need, like the in-network, out-of-network, co-insurance, deductibles, co-pay, everything that Cam was mentioning. So you need a way that you can actually do that, the hard verification of benefit detailed checks without needing to call a payer, because that defeats the purpose. Now you're just taking more time from your staff. So using automation to automatically get hard VOB details, being able to write into your EHR, tackling the COB problem that's usually leading to denials, and lastly, being able to have one kind of aggregator of all of the aggregators to be able to automatically submit, whether it's a prior auth or do a verification check from one specific area automatically. That's the main thing needed to effectively automate eligibility. And of course, we'll get into the whole prior auth piece. With that being said, thank you everyone who joined today. If you're all looking to learn a little bit more, obviously you can check out openbots.ai or email us directly. In my case, it's gs@openbots.ai. All right, everyone. Thank you very much.